dry, there's a lot of dead skin, high concentration of skin, should I say. The majority of earwax is actually dead skin in any case, around 60%. And the remaining 40% is a combination of a substance called sebum, which is secreted by the hair follicles, and it's an oily, fatty secretion, and also an accumulation of an oily sweat secreted by the same glands that are found under our armpits. These are called ceremunous glands, and the oily sweat, the oily, fatty sebum secretion combined with dead skin all amalgamates and forms earwax. Got the more lateral plug out, and this is the more medial plug, and it's quite a whopper in size actually, and it's quite a job wriggling this through the patient's ear canal, and you can just see how big large that is. The patient's eardrum's visible, although there is a slight attic retraction. So when we say the attic, we mean the top part of the eardrum. Other names given to that region is also the pars flaccida. The eardrum, the main body of the eardrum is called the pars tensa, so that's a stiffer portion of the eardrum, whereas the top part is called the pars flaccida, or as I said, the attic. And that part of the eardrum's less taut, less tense, and if you have eustachian tube dysfunction, which is when the eustachian tube is a narrow orifice that connects the middle ear, which is a cavity behind the eardrum, to the back of the nose. The eustachian tube is the pressure equalizer in the ear, and if that eustachian tube is blocked, it means there's no air behind the eardrum in the middle ear, so it creates a vacuum and your eardrum gets sucked in. And typically the pars flaccida, the attic region, gets sucked in because, as I mentioned, the eardrum's less taut, less stiff, more flaccid, hence the name. One of the questions from yesterday's video is, what is the name of the pressure test to diagnose the mobility of the eardrum, and if there's any negative pressure, it's called tympanometry. Now, this is the same patient, but their right ear. The reason why I reverted to using an ear hook and forceps is that the patient on this side found the microsuction sound a bit, not uncomfortable, but they did make comments that, oh, it's a bit louder, and I could tell by their facial expressions it's probably a bit, they were perceiving it a bit too loud. So I decided to revert to a manual extraction. I was able to, in hindsight, probably should have actually used an ear hook and forceps initially. Because the patient tolerated it well in their first left ear, I decided to, of course, just thought it would be the same in their right ear, but there was an opening at the top. So I went back in, used an ear hook and some forceps, managed to extract that plug of dry wax and skin. They've also got some dead skin flakes on. This is the anterior canal wall, so the front part of the ear canal. It's quite lateral near the entrance. You can see a bit of wax just beyond that, and I'll get that out with the Jobson horn in a moment. Similarly to the patient's left ear, their right eardrum, again, it's retracted. It's sucked in the attic, the pars flaccida, due to a blocked eustachian tube. The patient does suffer from nasal congestion. They have been prescribed some nasal decongestion spray, so hopefully that will resolve. One of the other questions from yesterday's video is, when you get I think it was a general question really, but it doesn't have to be an infection, but when do patients experience an immediate relief when you remove a plug of wax? Most commonly, yes. That's all the remnants of both ears of that patient. Sometimes it's not, very rarely, it's not an immediate, when I remove the plug of wax, I think, oh, this is going to be an instant relief for them. And sometimes it can take a while because their brain's so used to not hearing, it's a bit bewildering for them, and they have to acclimatise and re-equilibrate to their environment, and the brain has to adapt. So, but yeah, more often than not, it is an instant relief. This is patient 2. Now, this patient's got really bendy, twisty, upwards inclining ear canals. Most ear canals do have an upward trajectory of around 30 degrees. This is far more, probably 40, 45 degrees. Again, quite dry wax, higher concentration of keratin. Again, we know that because you can see it's quite glossy in appearance. The more glossier earwax is, the more dead skin keratin that's it's consisting of inside. This remaining plug of wax, dry skin, is very deep in the ear. When I remove this, you'll be able to see the patient's eardrum, and you'll have an appreciation of the anatomy of this patient's ear, because the eardrum's almost the bottom part, the superior part, is quite difficult to view because the ear canal goes, as I said, it's an upward trajectory, and then it suddenly spikes downwards. There's a sudden decline. So it's almost like seeing the eardrum past the mountain peak. So slowly just wriggling this out, a few matted hairs as well. Whilst I remove this, I'll just think of some other questions from yesterday. Someone asked, I think, about making sure the ear's dry and could they use rubbing alcohol. I think rubbing alcohol, it can sting. I wouldn't recommend to put that in the ear per se. And I think there's asking if when you suction, doesn't it dry? It does a bit, but the dampness is still there. The skin's absorbed the water, you see. So suctioning alone won't, and you can't over suction as well because it is quite noisy and people can get dizzy, the caloric effect. And you'll see now, so the ear canal goes really up and then suddenly it dips down where the isthmus is. The isthmus is the narrowing of the ear canal, which everyone has about 0.5 centimetre away. So the bottom part of the eardrum is actually almost out of view, just mopping up near the entrance. Another question I received yesterday was whether I offer any other services other than earwax removal. Well, yes, I'm an audiologist, and as an audiologist, my role is to diagnose, treat and rehabilitate those people suffering with hearing loss and also sometimes balance disorders. So I do perform some balance assessments as well, and give some exercises for certain conditions of balance and causes of vertigo. In addition, as an audiologist, we do hearing tests, diagnostic hearing tests, and I prescribe hearing aids. So there are some of the other services I provide. Another question was whether I take swabs of ear swabs to confirm the exact nature or strain of bacteria or fungi. I don't as an audiologist. In the UK, that's all done by the GP. It would be great, obviously, if we were able to do this, and get it examined privately. I'm sure there's probably a market there, but with infections, because audiologists don't prescribe, it's almost a pointless exercise. So we leave that to the GPs and nurses to conduct. Another question was whether there's a benefit of having patients sat. So most of my patients are sat during the procedure, but some patients, well, very few in my experience, prefer to lay down. It's kind of individual preference. I tend to find patients are more comfortable if they're sat in a natural position. I try to keep them as natural as possible, and it works really well for me, but other audiologists might have their own preferences. You can see 2 huge pieces of dry wax keratin removed from the right ear. Similar to the left ear, it's quite an upwards inclining ear canal, and the eardrum's almost trying to hide away. You can see it's just to the right. You can see just how bendy this is as well. It's quite twisty, bendy, and an upwards steep incline. I'm just going to answer a few more questions. A quite specific question about someone who's been on the bus for about half an hour, and when they got off the bus, they have a strange sensation of hearing cars whiz past them. I'm not sure of that diagnosis, but I can only assume it's to do with the altitude pressure change in your ear, and it takes a few minutes for your eustachian tube to equalise the air pressure either side of the eardrum, so you can have a strange sensation. That happens to me sometimes on a train, for example, when I go under a tunnel. Other questions were, why is it sometimes that one ear has got wax and not both ears? It's a very good question. It could be due to the anatomy of the ear. One ear could be more prone because it's a narrower, twisty, hairier ear to stop wax from naturally migrating. It could also be because they wear a hearing aid or use cotton bud in a particular ear. So generally, it could be genetic. So it's a very good question. There's a number of reasons why. I think another comment was whether it's I've thought about using a cotton bud just to soak up the hairs from the hair strands near the entrance. It's never really affected me, so it's just an extra unnecessary thing for me to do, hence why